Thanks, Jeremy. I just want to check that everybody can both hear me and see the slides.
Yeah, looks perfect.
Okay, great. Two kind of disclaimers. The first is that my internet connection has been a little bit unstable, and I am at work, so I don't know why Wits is behaving this way, but I'm hoping that it's going to be okay for the duration. And then, of course, secondly, my disclaimer is that I'm no expert in the prevention of surgical site infections. And I do also have some difficulty sometimes when I'm talking about things that are guideline driven that, I'm like, well, everybody can read. I'm not sure what I'm supposed to say other than the guidelines, but I hope that this is not too dull and that everybody learns a little bit from the presentation. So thanks for having me, and I'll get started. All right, so everyone who's listening obviously knows that hospital-acquired infections are a major burden to healthcare systems and economies in general. In high-income countries, 7 in 100 patients develop hospital-acquired infections, and double that in lower and middle-income countries. And that's, a little depressing, but not really surprising, considering how long people wait in our hospital for investigations, how overcrowded we are in general, and the other challenges that we face with IPC. In lower and middle income countries, 1/3 of all patients undergoing surgical procedures complicate with surgical site infections. And in Africa, 20% of all women who have cesarean sections also complicate with infections. It is the most frequent hospital-acquired infection worldwide, and yet the most easily prevented. There does seem to be some dispute in the literature regarding what's top of the list at the moment for hospital-acquired infections, but the 2018 WHO guidelines say surgical site infections are number one. In the US, patients stay for almost 10 days longer in hospital if they develop surgical site infections, a week longer in Europe, and on average 20 days longer in Japan, depending on the type of surgery. So, for example, patients who've had cardiothoracic procedures in Japan stayed for about 45 days over their expected stay, or their comparator stays. And obviously, complicated, prolonged courses of disease result in additional costs. So we, unfortunately, in South Africa have less efficient hospital-acquired infection surveillance, and there's no national reporting system for facility data. The table here is from a study performed at the Kimberley Hospital Complex in 2016. It's a point prevalence survey of hospital-acquired infection, which shows that almost 60% of the infections were surgical site infections. They were mostly superficial incisional infections, and we'll come to some definitions a little bit later. And then the second in line infections were UTIs. All right, so this was a study published in 2022. And this was a review of 15 PPS studies in Africa, points prevalence survey studies in Africa, including 2 from South Africa, and one of those from South Africa was the study in the previous slide. Firstly, hospital-acquired infections in general are twice as common as in developed countries, twice as common in Africa as in developed countries, and that's in line with the stats that we mentioned earlier. But more importantly, again, surgical site infections were the most common hospital-acquired infections, making up 41% of all infections. And this was followed by bloodstream infections in this analysis. Surgical site infection means any infection that occurs after surgery in the part of the body where the operation took place. So any of the tissue and sites that were involved in that procedure. They're classified as superficial incisional if the infection involves the skin or subcutaneous tissue, and deep incisional if the infection involves the deep soft tissue, which means the fascia or the muscle, and as organ or space soft SSIs if they involve obviously organs or spaces. And the time frame for calling an infection a surgical site infection is generally regarded as 30 days after the surgery itself. But if this is deep incisional or space sepsis, and there's also been a prosthesis inserted or something like sternal wires have been involved, then it can still be called a surgical site sepsis or infection if it's a year after the implantation of that prosthesis. So just a couple of caveats as far as the definition of the definitions are concerned. A wound is not considered a surgical site infection if there's just a stitch abscess. So that doesn't count as a surgical site infection. And the infection is not considered superficial only. It's not considered a superficial incisional infection if it's present as a result of an episiotomy or a circumcision or a burn. So those would be considered incisional. And organ or space superficial SSIs, the category includes infections involving anatomic structures that were not opened or manipulated during the operation. So if there was surgery and the colon wasn't opened and there's abdominal sepsis, there's a space infection, it's still considered surgical even if the colon wasn't opened, for example. So in addition to those definitions, the fact that it needs to be related to the surgery and be within a certain time frame, there do need to be some other things present. So a superficial incisional infection, there needs to be a purulent discharge as well. There should be organisms isolated from fluid or tissue of the superficial incision. That I think is often a challenge in practice because samples are often not sent prior to bionics being started, but ideally what you would want is an organism isolated from the site of the superficial incision. There should be at least one sign of inflammation, so redness or pain or swelling or etc. The wound should have been deliberately opened by the surgeon, so not a stab wound, for example. And surgeon or a physician declares that the wound is infected. So somebody may say, yes, I believe this wound is infected. That's the operation, and you don't want somebody to call your surgical incision infected. You might decide that you are not going to declare the wound infected, but it does form part of the definition. Okay, so for deep incisional, again, be a purulent discharge from the deep incision, but that the organ or a space is not involved. There should be fascial dehiscence, or if the fascia has been deliberately separated by the surgeon because there are signs of inflammation. So it looks like it's going to dehiss anyway. The surgeon decides he needs to open it up in order to release any pus or something that's present. If a deep abscess has been identified, and that means if it's been identified either clinically on a specimen, so by histopathology, or if there's a scan that shows that there's an abscess. And again, if the surgeon or physician declares that there's a deep incisional infection that's present. And then for an organ space infection, again, a purulent discharge, drain that's placed into an organ or a space, that organisms have been isolated by an aseptic technique, that an abscess has been identified, or that a clinician declares that there is organ or space infection present. Okay, so another couple of definitions. So there are 4 categories of surgical wounds or surgical operations. Clean surgery, clean contaminated surgery, and dirty surgery. So surgery refers to an uninfected operative wound in which no inflammation is encountered at the time of the incision, and that any of the anything with a lumen is not entered. So the respiratory tract, the gastrointestinal tract, genital or urinary tracts are not entered. So in other words, that there is no incision into a normally colonized viscus. So you would expect bacteria to be present in those, or maybe perhaps not in the urinary tract, but you would expect bacteria to be present in many of those sites, and that would be normal colonization, but you don't open any of those sites during clean surgery. And this category includes non-penetrating blunt trauma. There also needs to be primary closure and no breaks in aseptic technique. The pathogens that you find here are expected to be contaminants from the operating theatre, hopefully few of those from the surgeons, and most commonly, obviously, from the skin. And because it's most commonly from the skin, you would often see Staph aureus. For this category, the expected rate of surgical site infection is 2% or less. So if your hospital consistently sees rates that are more than this, there is an issue somewhere along the surgical pathway. So you would expect very low rates of surgical site infection for following clean surgeries. So clean contaminated refers to an operation in which a hollow viscus that is usually colonized, as mentioned previously, is opened. It's open under conditions and isn't any unusual contamination. So there's expected to be some degree of contamination, but it's controlled. It isn't a large spill. There hasn't been a mistake. The operation has gone according to plan. And that would include operations like anything involving the biliary tract, the appendix, the vagina, the oropharynx. And it does actually also include opening the colon, provided all the other criteria are met, that it's controlled and it's not an unusual degree of contamination. For this category, there should be no evidence of infection. So you know, for an appendix, open it up, the appendix looks inflamed, but it hasn't, you know, burst or anything. It doesn't, you know, there's no evidence of infection already in the space, and that there's no major break in aseptic technique. So this suggests that there can be minor breaks in aseptic technique, but no major breaks in aseptic technique. And the rates of surgical site infection in this category are expected to be somewhere between 4 and, oh, sorry, that's supposed to say 10%, between 4 and 10%, not 20%. All right, and then the next category is contaminated. So contaminated surgeries are any operation where there's gross contamination, but without evidence of infection already. So this might be a penetrating abdominal injury. So some come into the hospital fairly quickly. There is contamination in the abdomen, but there's no infection present. Also, for example, accidental gross spillage from the GIT. So you have an elective surgery, you open the colon, you're not as careful as you should be, and there's gross spillage into the accident. But obviously there's no infection at that time. And it also includes non-purulent inflammation. So for example, that might be associated with necrotic tissue. So there's no infection present, but the bowel looks necrotic. In my mind, there is some overlap here between clean, contaminated, and contaminated categories, because, you know, an appendix might have evidence of acute non-purulent inflammation. There might be some necrosis, you know, otherwise obviously you wouldn't normally be taking it out, hopefully, but the surgical technique is controlled. It doesn't result in gross spillage. So I think there's probably some degree of overlap between clean contaminated and contaminated in some circumstances. This category includes major breaks in sterile technique. So if you've had to, you know, if you're had to resuscitate a patient during cardiac surgery, there's been open cardiac massage, that's considered a major break in sterile technique. And that turns it from a clean contaminated or clean even surgery into contaminated. And contaminated procedures here are associated with infection rates of more than 10%. That's expected. And the most common organisms here are endogenous bacteria from the sites where there's that have been perforated. So then the last category is dirty or infected, and that includes any procedure where there's already active infection present, or any post-operative infection is going to result from the organisms that were already present at the site before the procedure. Because these are patients who may be going back to theatre, for example, you may find unusual pathogens there. If a patient's been sitting in the hospital, let's say in hospital acquired, or the patient has received antibiotics already, that may be a reason to find unusual organisms in these infections. All right, so the traditional risk model for assessing whether somebody is likely to develop a surgical site infection is really a very simple model. It's quite poorly predictive, and it's based on the US National Nosocomial Infection Surveillance Risk Index. And it consists of only 3 components, of the ASA score, which confers 1 point for any ASA score from 3 to 5. And for those of you who don't know, I obviously had to look this up as well. 3 is a serious condition that impacts the patient's overall health. And 5 is the score assigned to someone who is not expected to survive beyond 24 hours without the surgery. The wound classification confers 1 point for contaminated or dirty. And the procedure duration confers 1 point for any procedure above the 75th percentile for the duration of the procedure, which basically means that the definition of WHO guidelines is that if the surgical procedure lasts more than 75% of the surgical time, that's the risk. That duration is high risk. So the risk is stratified as low if you score 1 point, and as high if you score 3 points. And for me, I see a couple of problems here. The first being that, if you have 2 patients and you say that one has a dirty wound, where by definition, active infection is present prior to the surgery, but this patient has an ASA score of 1, so it doesn't get a point for that, and a quick surgeon, so it doesn't get a point for that. They end up with an NNIS score of 1, and so their risk is the lowest. As opposed to a patient who has an ASA score of 3, and that's what gives you the point, say ischemic heart disease, but is having a clean elective procedure with a quick surgeon. And, just intuitively, you would think that patient number 1 is much more likely to end up with a surgical site infection after that surgery. So for me, I don't think it's surprising that this, 3 category risk index is a predictive model. There are other factors that will also increase the risk, patient factors like nutritional status, smoking, infections distant from the surgical sites prior to the surgery, altered immune response, steroid therapy, having had another surgery recently, if they've been in hospital for a long period of time, and that's certainly going to affect our patients, colonization. And so, there are many different disciplines, surgical disciplines, that are looking for models that suit their own disciplines better than the kind of blanket risk assessment. All right, so there are suggestions for additional models other than the NNIS model, which include things like the high BMI, diabetes, reoperation, for example, arthroplasty revision, emergency surgery or trauma surgery. Surgery is open or closed. The use of a general anesthetic, obviously failure to give the appropriate antibiotic prophylaxis, the size of the hospital and the volume of the surgical procedures at the hospital. So obviously, if you have really good surgeons who do, 10 cases of kind of surgery and they're really good at it, then you would get the risk of surgical site infection to be lower for people who have more experience. So larger hospitals and a larger volume of surgical procedures is associated with lower risk of surgical site infection. But overall, it seems that more expanded and procedure-specific models still have a fairly low predictive ability, and may perform even less well for procedures that are uncommonly associated with surgical site infections. So it may be harder to predict surgical site infections where they're. So the next question is that given that many of these parameters are not modifiable, and if surgery has to be done, it has to be done, is there any real advantage in being able to predict a surgical site infection if you're doing your absolute utmost in terms of IPC and surgical asepsis, that you possibly can, and that's absolutely perfect? What's the point of being able to predict a surgical site infection? So if you think that your risk of surgical site infection in your patient is low, are you going to be less stringent in your aseptic techniques? Which surely not. So perhaps the value in a model with a better predictive ability is for its role in surveillance. Perhaps the advantage of a good risk model is in assessing performance at a facility level, or even in a unit, and subsequently then using that surveillance to guide changes to IPC or other practices, which may result in better performances in places where those SSI rates are higher than expected. So being able to predict SSIs and seeing if your rates are higher or lower is a way of identifying that there might be some issue. And then also perhaps the models have value in decision-making and counseling for surgeries that are not perhaps immediately required, so that if there are modifiable risk factors, they can be modified. A diabetic who's not as well controlled as they should be, for example. Or, if there's a surgery that is not required, a cosmetic procedure in a, penicillin allergic, obese diabetic with COPD, perhaps it's a way of counseling that person that perhaps this procedure has little value without and high risk. Okay, so the current guidelines recommend several things for the prevention of surgical site infections. And this is more than just giving an antibiotic. But when giving an antibiotic, the principles of prescribing obviously still apply. So while right drug, right dose, right route are all still important, when it comes to antibiotic prophylactic surgery, the right time is also extremely important to both the problem. And the right when they, 3 days, 5 days, whatever. In this circumstance, the right duration might be kind of misleading because the vast majority of the time, a single dose is all that's needed. So we really shouldn't be talking about duration. We should say there's no duration. A couple of other things, in addition, glycemic control is important during surgery. Normothermia throughout surgery, and that's a temperature of more than 35.5, glycemic control of less than 11, which is, not that tight. When we talk about normothermia, obviously that means where possible, there may be reasons for having a patient hypothermic during surgery. So, a cardiopulmonary bypass or something like that, you might have to have the patient cold. But for the vast majority of time, you should keep your patient normothermic, and that's more than 35.5. And then reduced tissue oxygenation is associated with an increased risk of surgical site infections. So an increased FiO2 is recommended during surgery, and that's an FiO2 of 80%. So during surgery and just after surgery. But obviously that's only going to be possible for patients who are receiving general anesthesia, who are intubated, because you can't deliver that high dose of oxygen unless you're using a ventilator. It's also recommended as for just after surgery, and what they say is 6 hours after surgery. And the WHO qualifies this by saying if feasible. And I think what if feasible means really is it applies to patients who can't be extubated post-surgery for whatever reason, somebody who's going to ICU, because you can't reasonably expect a patient to be ventilated in a recovery room for 2 to 6 hours just to get a high dose of oxygen. So, so if feasible means if the patient is remaining on a ventilator. And obviously it doesn't apply to patients who are getting regional anesthesia of one sort or another. Okay, so just to mention a couple of the other things, I'm obviously not going to go through the IPC procedures related to sterilizing equipment, because that's like a whole degree on its own. But I kind of like this picture as a reminder about all the places that we put our hands all the time. This is an indication of which parts of the operating theatre need to be cleaned between patients. Those that need to be cleaned if they've been used during the surgery, extra cleaning, and then if the walls are soiled by something, then you clean the walls as well. That's obviously that's post-surgery. Obviously, you do it during the processes of cleaning as well. So some basic principles is cleaning: clean with a detergent and then disinfect. So the point of using a detergent and normal cleaning with a detergent is that it improves the of cleaning, because it removes the actual biofilm. Not every surface needs to be disinfected, but any surface that has come into contact with blood or body fluids does. You clean high to low, ending with the floor. You clean the cleanest area first, ending with the dirtiest area. You throw away your cleaning fluids after you've used them. And you should be avoiding any kind of cleaning method that generates aerosol. So you don't spray stuff, you don't sweep, you don't dust. Okay, and then also a clean patient is a good place to start. The patient should bath or shower the day before or on the day of surgery to reduce the bacterial load on the skin. The UK hip and knee arthroplasty bundle recommends bathing or showering every day for 3 days prior to surgery. And some guides suggest that, showering is better than bathing in the bath. Anecdotally, I mean, I don't know how many other people have had surgery, but I've had surgery before. And I was never instructed to bath beforehand by the surgeon or the anesthetist. I suppose that, I don't know, I should be pleased. They assumed that I would. But, if it had been my kid, it might have been a different story, because it's harder to get her in the bath. So, I think a lot of assumptions are made that people do bath on a regular basis, and that may not be correct. Then bathing should occur with soap. Soap should be used, but any kind of soap is okay. You don't have to use an antibacterial soap. You don't have to use a chlorhexidine. Patients who are known to carry Staph aureus in the nose should be treated with mupirocin 2% ointment in order to attempt to remove that carriage. And that is a recommendation if they are orthopedic surgery in particular. And treatment can be considered for other kinds of surgery as well. They can with a chlorhexidine wash. So there's no decision, there's no recommendation made on whether or not you have to or don't have to use a chlorhexidine wash for patients who have nasal carriage. And this recommendation has kind of varied across guidelines over the span the last. And some guidelines recommend screening for all high-risk patients, procedures, and some for all procedures altogether. Some say screen only for MRSA. Again, the hip and knee arthroplasty guidelines are quite aggressive in this regard, saying that you should screen should screen all your patients who are having replacements, and that they should get mupirocin for 3 days before surgery, and they should have chlorhexidine baths for 5 days before surgery. So overall, it does appear to be quite a cost-effective intervention to give them mupirocin ointment. It saves about, in one particular study, it saved about €2,000 between patients in terms of the costs for surgical site infections between patients who received mupirocin ointment and those who didn't. So it does vary in terms of whether you try to eradicate nasal carriage, but the current WHO guidelines recommend that for patients who have known Staph aureus nasal carriage, you should attempt to eradicate. Okay, so then we move on to surgical antibiotic prophylaxis. So the current guidelines for prophylactic antibiotics is that antibiotics should be given for most surgeries. And that's except for clean orthopedic surgeries where nothing is implanted and for low-risk laparoscopic procedures. So I must say, I kind of struggle to think of a clean orthopedic operation that didn't need an implant. But I guess something like carpal tunnel surgery would fit the bill. And I guess a low-risk laparoscopic procedure might be something like a sterilization. The guidelines for antibiotics are fairly simple. You give them within 120 minutes of the incision. And the goal is to have good tissue concentrants at the time of the incision and throughout the procedure. So prophylaxis is given, if you give prophylaxis after the incision, that is associated with an increased rate of surgical site infection. And if you give it longer than 120 minutes before the incision, that is also associated with higher rates of surgical site infection. So what you want is within 120 minutes. If you have low concentrations at the time of wound closure, that's also likely to result in surgical site infections. Well, not likely to result, but there are higher rates associated with low tissue concentrations at the time of wound closure. According to the current WHO guidelines, any time within the 120 minutes is acceptable. But you do need to give some thought to the guideline, to the half-life of the antibiotic that you're giving. So for example, most of the time we're using cephalosporins, they're very commonly used. Probably any penicillin should probably be given within 60 minutes of the incision. And if you are giving an antibiotic that needs some time to infuse, like vancomycin or a fluoroquinolone, that also needs to be taken into account to make sure that you have the antibiotic infused and available with high tissue concentrations at the time that the incision takes place. So the WHO, in their meta-analysis for the 2018 guidelines, didn't find any evidence to support a difference in efficacy between 120, 60, 30, and 0 minutes. I would be reluctant to give my antibiotic at the time I'm actually cutting the skin. I think that's unlikely to result in adequate tissue concentrations at the time of the incision. So that to me, they may not have found any evidence for it, but I think intuitively it wouldn't make sense to give it at the time of the incision. The IDSA and the associated bodies, they're a whole group of bodies that develop the American guidelines. They're currently revamping their surgical prophylaxis guidelines. They're about 10 years old now, from 2013. And they suggest slightly different timing. So their guidelines recommend within 60 minutes and not later than 15 minutes before the incision, so that you can get those adequate tissue concentrations by the time the bacteria are actually being inoculated during the incision. The European 2013 guidelines and our current NDOH guidelines are in line with the under 60 minutes recommendation. So then redosing. So additional doses of antibiotics should be given during the procedure if it runs for more than 2 half-lives of the drug, or if there's excessive blood loss. So for the most commonly used antibiotic, which is Kefzol, the second dose would be required if the surgery runs for longer than 4 hours. If you're using metronidazole as well, which you may sometimes use for in certain situations, the second dose would be given after 8 hours. And one hopes, obviously, that most surgeries aren't going to run that long. Excessive blood loss obviously depends on the size of the patient. But in an adult, it's about 1.5 liters. And that means that the antibiotic, is going to be washed out by loss and then, by replacement by transfusion. So Kefzol is appropriate for most surgeries, with the addition of metronidazole if you think that anaerobic cover is required. I've got a few tables from different guidelines. This is the recommended South African NGOH for antibiotics for different kinds of surgery. It's available on EM guidance. And as mentioned, Kefzol is okay for almost everything. Metronidazole for GIT as well, drops for eyes and ears. And these guidelines also suggest considering prolonging post-operative prophylaxis for cardiac surgery for 24 hours. So that's one caveat to the qualification that you don't continue prophylaxis after the surgical procedure is actually over. Clindamycin is an alternative for beta-lactam allergic patients, and gentamicin can be added for operations requiring more gram-negative cover, like those highlighted on the table. So the gentamicin that is there in red, I've added myself. It's not in the original table, but it's in the original. But it's in the text of the document itself, and it's just easier to add it to the table. Okay, and this is the SASP guideline. This is from 2015. As far as I know, it's not been updated, and it's actually quite hard to find this guideline at the moment. And it's very similar, some alternatives as well. Also, just to bear in mind that it's possible to consider, according to the Gauteng Provincial Antimicrobial Stewardship Committee guideline on surgical prophylaxis, it's possible to consider coamoxiclav as an alternative to the Kefzol metronidazole combination, which is obviously designed to cover the anaerobes. Okay, and this obviously is a small table, and I apologize for that, as well as for a couple of other tables that may be coming up. These are the IDSA guidelines, which includes this table, which is a much longer list of antibiotics. And it's a little nerve-wracking that the title of the table is that these are commonly prescribed and antimicrobials for surgical prophylaxis. I think many of us would be very uncomfortable using some or even many of these as prophylaxis. Ertapenem is in there, for example, but carbapenems would, I think in general, not be the preferred choice for surgical prophylaxis. Having said that, I guess it's always best to refer to the local antibiogram and then to choose the narrowest appropriate spectrum antibiotics for the type of surgery and the organisms likely to be inoculated. There is also, just for your reference, an extensive list in these IDSA guidelines about the specific choice of antibiotics for different kinds of surgery. But again, to bear in mind that if you're going to use international guidelines, and in particular these ones, they do tend to be quite a lot more liberal than ours or most guidelines. For example, they use first and second generation cephalosporins kind of interchangeably. They say you can use Kefzol or cefuroxime, and that's not generally what we would support. Okay, and then this is just a little bit about organisms. This is from an American study, and from the surgical site infection data that's reported to the National Health Safety Network. It's very nice to have a reporting system like that. This table is from 13 years ago, and there may well be differences in resistance patterns now, but it's quite nice to show the rates of the different types of organisms most commonly encountered. So Staph aureus is number 1, followed by CNS, and that together they count for about 42%. That's followed by E. coli, accounting for another 10% or so. and then Enterococcus faecalis, Pseudomonas, Enterobacter, and Klebsiella. And in our setting, I think we'd certainly be keeping an eye out for that Klebsiella. Okay, so this again is quite a nice table. It gives you an idea of the types of organisms you'd expect from the type of surgery, which guides the recommendation for the choice of antibiotics. So Staph aureus obviously makes an appearance anytime you cut through the skin. But the surgeries that involve opening bowel will more likely be contaminated with enteric organisms and anaerobes. When the oral mucosa, for example, is involved, group E strep during gynae surgery. So these are kind of site-specific organisms, and they make sense. And it's important to bear them in mind if there's any reason to consider deviating from a guideline for surgical prophylaxis. Okay, so there is quite a lot of deviation from guidelines for surgical prophylaxis prescribing. This is a study published in 2018. It's a local study, and it's the questionnaires were supplied to anaesthetists who are employed on the VIT circuit to ask them to assess their knowledge of surgical prophylaxis. And it included questions on timing, duration, redosing, antimicrobial spectrum of the antibiotics and indications for giving surgical prophylaxis. The average score was 56. The senior staff did a little better. So, they got scores of 59%. The junior anaesthetists got a scores of 53%, but, a 6% difference is unlikely to make any material impact, on practice really between the two groups, I would think. The main areas where knowledge was lacking was with the exceptions to the timing rule. So for vancomycin and, fluoroquinolones, you need to give a little bit more time to infuse. And then the duration of prophylaxis, with most participants answering that prophylaxis should be continued beyond the intraoperative period, and many that it should be continued beyond 24 hours. So that was an area where they fell down in particular. Okay, so it's all very well to have guidelines in place, but if you don't know what your surgical site infection rate is, and you don't know what kinds of surgical site infections are occurring, and you don't know what the organisms are, and you don't know what the antibiotic prophylaxis that's being prescribed is, and you don't know if there's adherence to the other interventions in the bundle, then you really can't know if you're doing anything right, what you're doing wrong, and how you should fix it. And unfortunately, we are kind of in that situation. At my hospital, I can give you some anecdotal information, which is that there's a very small amount of surveillance for surgical site infections. It's intra-departmental. So, the gynae department has their own registry. But really, the records are of an occurrence of a surgical site infection and not any of the associated features that might be able to guide practice change. So you say, yes, we had this many cesarean sections and we had this many surgical site infections, and that's the information that you collect. And that's not useful if you need to try and change practice. So if you were to then set up a surveillance program, it would need to meet certain requirements. And, the most important of which I think applies to any kind of surveillance is that it's a standardized system. So you need to include a written plan. You need to have some kind of SOP that says these are our goals and these are our processes. And then once you have decided what your goals and processes are and what you're going to measure, that you maintain a consistent intensity of surveillance of consistent elements. So you have to measure what you're measuring all the time, and you have to measure the same things all the time. And this, of course, requires, a major human resources commitment, which certainly few services can provide. There's certainly going to be no dedicated personnel for a new program that you might want to implement, as well as IT support, which is constant problem, obviously, for all of us. And that's on the background of appropriate record keeping. Then you've got to follow that by consistent evaluation of the data, and then you've got to feed back to the unit in the hospital. Without feedback, evaluation is worthless. The rate of surgical site infections would usually be assessed as the number of surgical site infections over the total number of procedures, rather than the total number of patients who are having procedures, because, obviously more than one procedure may be followed by a surgical site infection in the same patient. And that, of course, is not sufficient. As we said, it's not okay just to say there was a surgical site infection. What you need to do is you need to collect additional information. You need to collect demographics. You need to collect patient characteristics, the kind of surgery, the kind of wound, and the infection type need to be included. So obviously, all active surveillance is very resource and time intensive. Direct prospective surveillance would be ideal, but I would suggest virtually impossible in our resource limited environment. Indirect surveillance can be accomplished by looking at micro reports, looking at the patient's records, surveying surgeons, surveying patients, screening for readmission, screening for relooks, among other activities. But indirect surveillance still requires people and time. There's just this link at the bottom here is just a useful page. It's kind of a nice step-by-step implementation kind of page on setting up a surveillance program for surgical site infections. Okay, so yes, I apologize for this terrible tiny table. So unfortunately, it appears to be very hard to get prescribers to change practice and adhere to guidelines when it comes to surgical site infection. I think that applies to any kind of antibiotic prescribing. And I'm sure many of us face these challenges on a daily basis. And it's hard to get people to change practice or adhere to guidelines just by education. And often what you need is a more formalized institutional intervention. You need to make things a requirement. And this is an article detailing a program that was implemented over a 2.5 year period at Netcare hospitals in South Africa. And I'm certainly not suggesting that Netcare hospitals are the same as government hospitals, but it is an interesting program. So there was a pre-implementation phase where a team was assembled. This team was over and above those who were involved in multidisciplinary AMS activities already. So those multidisciplinary teams that predated this intervention didn't have any surgeons or anesthetists on them. So now the teams that were assembled included anesthetists, and that was obviously beneficial all by itself. And then based on local and international guidelines, the hospital group developed and distributed their own guidelines. They conducted audits of at least one surgical procedure, and then they assessed compliance with the guidelines. This was then followed, so that was a 4-week period. This was then followed by an implementation phase. And that included the recording of the SAP indicators, which were, dose, choice, duration, et cetera, as well as the surgical site infection rate. And then feedback was provided on those SAP indicators, but not on the surgical site infection rate to those individual hospitals. And the feedback was individualized for those different hospitals. The data was then provided to the pharmacists, who then presented it to the surgeons and the anesthetists and the AMS staff at, in various ways, at in the tea room at theatre, at AMS meetings, at multidisciplinary meetings, and so on. So they were consistently providing feedback. And so this engagement was obviously very intensive, but it bore fruit. So firstly, the things that were measured was compliance with the guidelines, and the compliance with guidelines improved significantly following the implementation. And most importantly, there was a decrease in surgical site infections after implementations. So a couple of things should be noted is that most of the hospitals, they could choose which surgeries they were going to audit, and only clean and clean contaminated surgeries were audited. But there's a before and after comparison, and there's an improvement in surgical site infections in that subgroup of surgeries. It was a multi-center study, so 34 South African hospitals, and there were differences in the approaches at each hospital. It's not possible really to tease out which of the interventions at each site was most effective. So especially when what happened is that, there'd be an audit and a feedback process, and there would be different interventions at each of the hospitals following that feedback process. So it's not a blueprint by any means for a program that can kind of be copied. It's obviously backed by a greater or a more filled coffer than we would have. People were employed to implement these programs. So it's not something that can just be copied, but it certainly suggests that interventions are possible and that they do work. So really the take-home messages are guidelines are readily available. Surgical antibiotic prophylaxis is not treatment, and treatment is not surgical antimicrobial prophylaxis. Surveillance is important to facilitate interventions. And as with all AMS, interventions are hard, but worthwhile. Thank you very much for your time.
Thank you so much. We need to find out a way of having applause buttons on this thing. But thank you so much. That's really, really handy and a great overview of a really important topic. Got some questions. I don't know. I think Adrian's on the line. I don't know, Adrian, if you want to add anything at this point. Otherwise, I'll go to some other questions as well.
Hi, Jeremy. I'm just making myself warm. Thank you so much for the lovely presentation, Sarah. I just wanted to make a comment regarding the intervention in the Netcare hospitals. Initially, we did approach the surgeons, but they were not really interested in, at that stage, in giving us some support in the sense that they leave the decision to the antibiotic choice and duration and timing to the anesthetist. And so that's the first comment I would like to make. And the second one regarding that intervention is that it was clear that we needed a multidisciplinary approach. You can't do it on your own. And so we recruited partners, it doesn't matter who they were. In many hospitals, we had very passionate theatre nurses who felt this was very important. And so in some of the institutions, the leadership of the perioperative antibiotic intervention was actually a theatre nurse or a theatre matron. The biggest third comment I'd like to make was measuring timing, because we didn't have funding to have a CRA record the timing. So in the end, the multidisciplinary team grew in that we were using ward and surgical nurses in the intervention to actually record the timing of the drug. And then we still had institutional failure in getting it in an hour, because in the private setting, you can't be admitted the previous night, you come in the morning. Now, where do you find the patient between arriving at the hospital and getting to theatre and getting it in an hour? So in the end, yeah, I think I did make the comment. The issue is, if you're going to do it, you would need a big multidisciplinary team. It's not only the ID doctor or the ID team that could implement something like this. The fourth comment, the audit and feedback was extremely important. as the surgeons saw that the surgical site infection rate dropped, it is an extremely complicated process, and we didn't do qualitative research to understand the dynamics. But once they saw that they didn't have surgical site infections, some people were using ceftriaxone for cesarean sections, or not kevazoline, which is the drug of choice as per the guideline. Once they had confidence in the system and in the audit and in giving it within a certain time and using kevazoline and using this dose and redosing and so on, the support turned very much in favor. And in many of those hospitals, I'm not there anymore, of course, at Moore Park, but in many of those hospitals, the surgeons are now forefront stewards of antibiotics because of the experience with perioperative prophylaxis. So and there were differences between orthopedic surgeons and general surgeons and cardiothoracic surgeons. So it's a very nice intervention to do, because eventually you bring a lot of people together. Thank you.
Thanks, Adrian. Can I ask you, do you have any idea whether people have stuck with it? I mean, it's a 2.5-year intervention. That's an intensive intervention. It's ongoing. And I was just wondering, since that intervention, are there people who persist with it? Are there people who are still measuring and monitoring and feeding back, or was it confined to the intervention?
Yes, they do, because they are audited. It's part of the corporate or the hospital group key performance areas. And so it became kind of standard practice. Of course, a lot of doctors are new, and then they arrive and then they don't agree with the guideline because they want to use ceftriaxone or some other drug that's not on the list. So it's a continuous battlement. But the key to success here and it was voluntary, was pharmacist involvement, because the ID doctor and the ID team and the IPC nurse can't provide feedback. We don't have time, but it's easier for them. Subsequently to the interventions, Sarah, they automated their prescription. They have a third-party warehouse where the antibiotic use is loaded up and the microbiology results are loaded up. And so it's easier for the pharmacist to control this compared to a paper-driven one, which is, at the time when we did that study and published it, we had to do it via paper. It's not the biggest problem, Sarah, to be honest, was IPC related, and that is to record the surgical site infection 30 days afterwards.
So when patients are home, I guess.
Well, the thing is, if you contacted the surgeons' rooms or the clinicians, nobody really wants to report a surgical site infection because they take it personally that they had failed during the surgery, or it's a very not strange. It's an area that needs to be studied from a qualitative stewardship research point of view, and so it was quite difficult to get surgical site infection rates. So eventually the team members, whoever they were, phoned the patient to find out, was everything okay? Did you come back to hospital? And therefore the labor-intensive part of this study was really getting surgical site infections recorded, because 30 days afterwards, the patient goes away, the patient changed address. It's a problem. Thank you.
Yeah, not an easy area.
Yes, Sarah, there's a couple of questions on vancomycin in the chat. I don't know if you can see there, but they are clustered two of them together, and then there's a third one. But so one of them is about asking this practice about vancomycin lavage to irrigate the entire surgical site with large quantities of vancomycin, and or do wound irrigation with vancomycin as a sort of preemptive or prophylactic strategy. The question is there any evidence to support this?
So I can't give you the evidence. I can give you the guideline, which is that there's the idea of irrigation of like the abdomen with an antibiotic is not supported.
Yeah, I agreed. And as you said, I mean, it makes sense. Why not? I mean, we're giving prophylaxis for the wound, and if you need to help with the operative field, say there's 4-quadrant contamination with pus or something, then you can give that systemically. There's no point trying to do peritoneal dialysis effectively with your antibiotics.
Yeah.
Through that. And then there was a related question from Evan just asking, is there any data on changing to vancomycin prophylaxis for those patients who've been in hospital a while, however long a while is? In other words, instead of something like ifazole.
Not that I could see. The recommendation for vancomycin is basically for penicillin intolerant patients, rather than if they've been in hospital a while. I mean, I guess that does to some extent depend on your hospital epidemiology, and if somebody's been in the ward for 6 weeks, and you have like very high rates of MRSA, perhaps that's worth considering, and the patient's having a cardiothoracic procedure or a hip replacement, then but there's certainly no recommendation for that particular reason.
No, I want to agree with Sarah. I mean, this local irrigation or topical vancomycin, there are even people who use cement that contains antibiotics in. It's not advised by any guidelines, and therefore that intervention in the Netcare group, we didn't include it. And we tried to convince people not to use it. I don't know where that practice comes from. I think initially in chronic or orthopedic infections, people were using the so-called Lautenbach irrigation to treat a chronic bone infection with a resistant staph. But from a prophylaxis, a surgical prophylaxis point of view, there's no role. And even all the new stuff available, like antibiotic-containing cement and so on, there's no evidence that it makes a difference. You've got to get the right dose at the right time, and you keep it short. But having said that, Sarah, Jeremy, this is a very complicated part of stewardship. It looks very simple, but it's not. For example, there is evidence that we should be doing dose adjustments for people that weigh more than 120 kilos. So at the moment, cefazolin is given to everybody at 2 grams without a dose adjustment to 3 or 4 if needed. So there's lots of work still. There are lots of unmet needs, data gaps that still have to happen globally to sort this out. Thank you.
I guess the other thing, I mean, I see that in the chat, the one of the things saying is it can be up to 8 grams given vancomycin peritoneales, that it may well not be, not only not efficacious, but actually harmful. I mean, that is an enormous dose of vancomycin. Some of it does get absorbed through the peritoneum. I couldn't tell you offhand how much, but it's not a trivial amount. So you really are giving systemic vancomycin there, just the hard way, and it may well not be great on that side.
Yeah.
And then just last question. I know we're a little bit over time, but there's so so many questions, which is a really good sign, I think. Judy's just asking, I think she's asking about the timing of the skin and soft tissue infections. So in other words, when would you be happy saying they're unlikely to develop a skin and soft tissue infection if it hasn't developed after X time, or is there no such time you could, that's really kind of lockdownable?
Well, I mean, the definition is for 30 days. So I suppose if you're being hardline about it, you would say that if it develops within 30 days and it's at the site of the surgery, then it's a surgical site infection, even if they're at home.
Yeah. Cool.
But the problem is, I think that we miss a lot of undocumented cases of skin and soft tissue, as Judy is asking, because they get worse at home, but they might not return to the same hospital. And that's why initially in phase 1 and the pre-implementation phase, we were relying on reporting from the clinical team that the patient had given us feedback, and therefore we switched to actually phoning the patient, because the patient came to Dr. X because there was because he's good, but normally they go to a different hospital group, or some people will go to 3 hospital groups. So if they don't come back to the same surgeon, they go to a different one, you're going to mess it up. Anyway.